Hello everyone, this is Kirutikan. Along with me, Aiden, Najme, and Serge, we'll be talking about an aspect of the Canadian healthcare system, and we'll be comparing its implementation to the healthcare system of South Korea. The aspect that we have chosen to talk about today is financing. Our agenda for today includes an introduction that describes the aspect that we have chosen, which is healthcare system financing. Then, we will talk about the strengths and weaknesses of implementation while making comparisons with the Canadian healthcare system to the South Korean healthcare system. Then, we will talk about the barriers of implementation, and at last, we will talk about the strategies that we have come up with to overcome the barriers.
First of all, let's see how much world spends on health. For example, in 2001, about $3 trillion, which is approximately 9% of global gross domestic products, was spent on healthcare worldwide. Next, let's take a look what changes were made into the health financing policy over the past years. For example, over the past decade, international health financing policy and principles changed from defining a basic package of cost-effective health services to studying and developing a way of financing the delivery of equal, efficient, and personalized health services. One important part of health system planning is defining cost expenditure. This activity is critical for reaching universal health coverage. There are three the most important areas of health system financing which are related to each other, and they are critical for reaching universal health coverage. First is raising funds for health. Second is reducing financial barriers to access through repayment and subsequent pooling of funds in preference to direct out-of-pocket payments. And the third one is allocating or using of funds in a way that promotes efficiency and equity. So what are the main health financing functions? First of all, it's raising money. Raising from household, businesses, and external sources. Second is merging the resources, with all the resources protecting all of the healthcare system stakeholders. First of all, patients, from the large unpredictable health expenditures. And the third one is purchasing healthcare system interventions.
Thank you, Serge. Now I'm going to be talking about the strengths and weaknesses of each country implementation. Canada Healthcare Implementation Strength maintains and improves the standards of 5 principles consistently to ensure high quality of acute healthcare. Portable coverage during short absences when traveling to another province in Canada. Public administration administered on non-profit basis where public authority is accountable to the government. Accessible healthcare should be accessible without paying any kind of user fees. Comprehensive includes all medically necessary services. Universality, do not need to pay for insurance as it contains all medically necessary hospital and physician care by province health insurance programs. Kansas healthcare service is not just limited to medical, physician, and hospital services, but all provide services with beneficiaries access that is different from health insurance plans that are distributed provincially. Aboriginal people, the military and federal prisoners, worker compensation board, automobile insurance, finance, healthcare, acute healthcare is covered for all Canadian citizens and residents. Fiscal transfers are equalized throughout Canada. Public taxation, 70% public funding and 30% private. Primary healthcare is covered for all Canadian citizens and residents. All citizens are covered during short absences when traveling to another province in Canada. Now I'll be talking about Canada Healthcare Implementation Weaknesses. Public taxation and easy access to acute healthcare in Canada has increased wait times. This has led to government incurring costs to incorporate various tools and programs to reduce wait times over the years. This includes building capacities for regional centers, expansion of community care and ambulatory services, implementing tools and system managed wait time. Only acute care is covered through public taxation government. Moving forward to South Korea healthcare implementation strengths, benefit packages have been expanded. Health prevention promotion services are included in the benefit package provided through national health insurance. Cost containment and efficient use of resources has positive medicine list systems that requires removal of medicine that aren't as cost effective. Federal government subsidized fees for families who cannot afford health care through national health insurance. Employees insured for health coverages. South Korea healthcare implementation weaknesses. Self-employed individuals are not covered. Fee for services. High out-of-pocket expenditures lead to problems of financial constraints that lack of access to healthcare for people who cannot afford these costs in Korea. Average of outpatient and inpatient services varies. Medicines tends to be uneven. The high cost sharing and other user charges for inpatient services. This includes special treatment charges for charging inpatients for special rooms. Due to the expansion of benefit package, there is increased pressure among population for government to expand services, and costs include in coverage when healthcare financed through national health insurance.
Additionally, according to Mahawar, with regards to the national health insurance contribution in South Korea, according to household survey data, higher income families are contributing more to the national health insurance. However, reports have mentioned that lower income families tend to spend more percentage of their income than families of higher income, thus coming across as a weakness for the South Korean healthcare implementation in the aspect of financing.
Now we are talking about the financial barrier. Financial barrier is more important for people with chronic condition who typically require ongoing monitoring and long-term use of costly prescription medication. People with lower socioeconomic status are more vulnerable to experience poor health outcome. As you see in this picture, there is a comparison between low childhood socioeconomic status and high childhood socioeconomic status. According to this picture, the developing a cold in low childhood socioeconomic status is 46%, which is higher than 25% in high childhood socioeconomic status. The percentage of Canadians reporting serious problem with paying their medical bills. The average annual out-of-pocket costs reported by older and sick adults in Canada ranged from $1,101 in 2005 to $1,135 in 2014.
It is also important to notify that high-cost user status was strongly associated with being older, having multiple chronic conditions, and reporting poor self-perceived health, which comes across as a barrier to the Canadian healthcare system and the aspect of financing implementation itself as well.
More than 1 in 10 adults with a cardiovascular-related chronic condition report lack of drug coverage and perceived cost-related barriers. So they are less likely to receive recommended medication, more likely to be non-adherent, and there are more hospitalization or emergency department visit for them. In previous slide, I talked about non-adherence. Non-adherence is a term that patient refuse the care unintentionally. Like the patient is overwhelmed, they don't understand, they are helpless and they are confused, but the most important things according to our topic, they are concerned with healthcare costs. Affordability of healthcare in Canada, including type of provincial drug coverage, out-of-pocket expenditures and cost-related non-adherence, which I explained in previous slide. And unfortunately, I have to say that out-of-pocket costs of medical treatment and prescription drugs not covered by either public or private health insurance.
Along with the barriers that Najmi had mentioned, there's also another form of barrier that has been identified that exists within the Canadian healthcare system. With regards to the financing aspect of implementation in the Canadian healthcare system, it has been found that services that aren't publicly taxed aren't considered to be acute care, also known as medically necessary, requires out-of-pocket payments. Some of the services that are not publicly taxed or funded by the government include eye care, also known as optometry, dental care, mental health care, and any forms of prescribed drugs. All these services will require patients to pay out of their pocket or receive a form of benefits package that isn't funded by the government. Otherwise, they will have to receive some sort of benefit package through an organization that is not publicly taxed to receive these services because they are not considered to be in a form of acute health care. Consequently, a lot of the Canadian patients and residents who are part of low socioeconomic status and households are actually finding it highly difficult to attain health care that aren't part of any acute medically necessary care, and they're finding it difficult to access these services. On that account, we will have to come up with certain strategies to overcome these barriers. Now we have come up with some strategies to overcome the barriers of financing that exist within the Canadian healthcare system. One strategy that we have come up with by trying to address health inequalities and to mitigate gaps between high and low income status levels by providing employment opportunities for individuals of low income status, so that way they would have more opportunity to receive any form of healthcare that isn't publicly taxed. Another strategy that we have come up with to overcome the barrier of financing implementation is to reduce high out-of-pocket expenditures for services that aren't considered to be acute or medically necessary for families that fall below the poverty line. That way, families of low-income households or individuals who fall below the poverty line will have access to health care that isn't funded by the government, which includes dental health care, optometry, mental health care, and prescribed drugs. The third strategy that we have come up with to overcome the barrier of financing implementation is to provide financial protection or insurance package for Canadian residents with chronic disease, so that way they can have access to healthcare services that isn't covered through public taxation. The fourth strategy that we have come up with is to increase educational opportunities for every family of low-income households, so that way we can mitigate the existing barrier that exists within the Canadian healthcare system. Through this strategy, students, especially the ones that are part of low-income households, will have opportunities to have access to healthcare, which includes dental care, mental health care, and eye care. So that way we can mitigate the barriers that exist with regards to financing. The final strategy that we have come up with to overcome the barriers with regards to the implementation of financing the Canadian healthcare system is to reduce health inequities by ensuring families of low-income households to not contribute a hefty portion of their income towards medications and care that isn't publicly taxed. This particular strategy will probably require families of high-income households to pay a heavier portion of their income towards medications and care that isn't publicly taxed. That way, people of low-income households will have more access to these services. As mentioned in one of the weaknesses of the South Korean healthcare system financing aspect, with regards to national health insurance contribution, it has been found that higher income families may be contributing more amount to the national health insurance, but data shows that lower income families tend to spend more percentage of their income than families of higher income. We over here are not trying to replicate the same issue that low income family households in South Korea are facing with regards to the Canadian healthcare system. It is also important to acknowledge that these existing strategies that we have come up with may incur costs for the government. However, we also believe that these strategies will be able to mitigate the barriers that exist with the aspect of financing in the Canadian healthcare system. Now that we have covered a few areas with regards to the aspect of financing in the Canadian healthcare system, we are now going to come to a conclusion. On that account, our next step is to emphasize on health inequities and reduce gaps between high and low income households, with particular attention being given towards patients with chronic diseases, which include diabetes, cardiovascular diseases, and respiratory diseases. Additionally, we are also aiming to provide low-income households opportunities to have access to other forms of health care that may not be funded by the government or may not be publicly taxed. We're also expecting that the government will be able to provide benefit packages for Canadian residents to have access to health care that isn't limited to medical necessities, or also known as acute health care. So that way they will have access to other forms of health services, which includes dental care, mental health care, eye care, and prescribed drugs. In addition to the strategies that we have come up with, we also should make sure that the government doesn't incur hefty costs to cover healthcare services that isn't considered to be acute care, also known as medically necessary. At last, we are also trying to maintain administration, accessibility, portability, universality, and comprehensiveness standards for vital medical health care, which we have been doing for many years. As we have made comparisons to the South Korean healthcare system with regard to the implementation of financing, we can come to a conclusion that the Canadian healthcare system's financing aspect does have more benefits and strength. However, we still do have certain barriers that need to be mitigated. Here is a list of references that we have utilized for our research with regards to both the South Korean healthcare system and the Canadian healthcare system. Thank you so much for listening.